I think it's time to start.
Yes.
Thank you very much for joining us today for the next edition of Oncology Beyond the Obvious. Already there is a great buzz on WhatsApp, thanks to our faculty and especially Amol for putting so many questions and doubts about what we are going to discuss today, Topaz. And the discussion started by saying, what is the full form of Topaz? We don't know that, right?
Mm.
So for those who have joined for the first time, Oncology Beyond the Obvious identifies one particular manuscript that could be potentially a landmark publication. And then we discuss that threadbare into dividing into three parts. The first part is when one expert is interviewed. The second is when another expert conducts a panel discussion and moderates it. And finally, the third expert who gives the concluding remarks on what is the relevance of this manuscript or publication in the day-to-day practice. So as you can see on your screen, the person being interviewed by Dr. Amish Vora will be Dr. Viraj Lavingia. Our moderator is none other than Dr. Ullas, Batra. And then we are privileged to have Dr. Amit Rauthan as the expert. So Amish is my co-director for this program, Oncology Beyond the Obvious. He's really worked very hard. And as we were discussing earlier, it takes a lot of hard work to set up this program, including dress rehearsal of the interview with the interviewee so that we can do everything, bring out the points within the time allotted. So without wasting much time, I now hand over to Dr. Amish Vora to introduce Dr. Viraj as well as start the interview process. Over to you, Amish.
Thank you, sir. And can I have my slide, please? So today we are discussing the topic that is the trial is Topaz 1 and Topaz 1 on the biliary tract cancer. Next slide, please. So this is an NEJM publication which was on June 1st, 2022. That is this year. And the title is Durvalumab plus gemcitabine and cisplatin in advanced biliary tract cancer. The publication, the investigators, the primary investigator is from Seoul, Korea. And there were rest of the world also. There were 17 centers across the world with 17 countries with 105 sites which participated in this trial. Next slide, please. So study design, very, very straightforward. And I must say that this is a phase 3 double-blind, multi-center global phase 3 study. But even phase 2 and subsequent earlier than that phase 1, please go through it because I personally believe that this is very diligently done study. Inclusion criteria, locally advanced or metastatic biliary tract cancer. This included intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancer. Previously untreated if unresectable or metastatic at initial diagnosis. Recurrent disease more than 6 months after curative surgery or adjuvant therapy, at least 6 months should have been passed with good ECOG performance status. Randomized 1:1 between Durvalumab plus gemcitabine and cisplatin, that is 1,500 milligram every 3 weekly. Cisplatin and gemcitabine is day 1 and day 8. In the placebo arm, there is in the experiment, in the control arm, gemcitabine and cisplatin, which is ABC02, identified a decade earlier, is a standard of treatment category 1 recommendation. Primary endpoint was overall survival. Secondary endpoint was progression-free, objective, and other things. Stratification was done between unresectable versus recurrent and intrahepatic versus extrahepatic versus gallbladder. Next slide, please. So this is the patient characteristics of this. And here, I think bottom line is in the 4th row, I would like to concentrate. Primary tumor type, intrahepatic CC was commonest, followed by gallbladder, followed by extrahepatic. Recurrent disease was hardly 20%, while initially unresectable was 80%. Metastatic disease was 88%. This shows that the participating centers had majority of the patients who were unresectable and metastatic to begin with. Viral hepatitis, there was no viral hepatitis in half of the patients. And MSI1, something which Viraj would love to talk about it, 50% of the patients MSI report was missing and high was 0.9 in other where it was reported. TAP, that is the new way of identifying PD-L1, was high in 57.8% of patients and negative in remaining patients, 30% and 12% was missing. Next slide, please. I am not going to go into the details of this. The tail, as always in IO study, is separating, and this tail basically happens in every IO. Whether it is significant or not is something which we all need to decide today. Okay, next slide, please. So objective response rate was, according to me, was slightly on the lower side. 26% was response rate in Durvalumab arm versus 18.7 in chemo arm. Slightly on the lower side in our clinical practice. But the important point is patients with continued response. If you see between 3 and 6 months and 6 and 9 months, there is a rapid drop. But if you see 9 and 12 months, there is not much of a rapid drop in Durvalumab arm as compared to in the placebo arm. Next slide, please. Forest plot chart, which any paper is incomplete without that. In the red box, if you see, the subgroup crossing the line of unity are extrahepatic cholangiocarcinoma, gallbladder cancer, and race is non-Asian. Next slide, please. In the PFS data, also focus on non-Asian. Non-Asian apparently in this subtype are not responding, even gallbladder cancer, if PFS and OS crossing the line of unity. Next slide, please. Safety-wise, it was quite safe. If you see, almost everything is exactly the same in both the arms. No new safety signal. Next slide, please. As a result of this paper, where it met its primary endpoint of improvement in overall survival, FDA approved Durvalumab in the first line setting in unresectable or metastatic gallbladder cancer in September of 2022. We can close the slide on this and we can go on to our discussion. So we have Dr. Viraj Lavingia here. Viraj is a very, very close friend. I would say is that I remember very early on, we met probably for the first time at the Nepal airport. And he was a very, very small, child-looking, very innocent face guy. And he said that, sir, I want to make my career in GI oncology. I said, very good. It is excellent idea. But do you know you are dealing with a small subset in a giant, medical oncology space? He said, Koi nahi, sir, let us try. I said, absolutely fine. We all are with you. And today, I don't think anybody in the oncology fraternity or anybody in the gastroenterology fraternity or anybody in the GI cancer fraternity doesn't know Viraj. Viraj has made his mark in GI cancers. In terms of the education, Viraj has done his MBBS and then DNB in internal medicine and then DNB in medical oncology. He did a lot of fellowship in GI oncology, especially in hepatic artery ablation, what I see. He has got a good experience abroad. In addition to that, right now he's working as a senior consultant in HCG of hospitals. And at least me, whenever I have a problem in GI cancers, I pick up a phone and talk to Viraj and I say that, Viraj, help me out. And invariably, he has an experience definitely more than me. I welcome you, Viraj, on this platform. Thank you so much for joining.
Thank you, Dr. Amish. Very kind words. Thank you. Pleased to be on ABTO.
Not at all. It is, our honor that you are here. So Viraj, can we start our discussion?
Sure.
Perfect. Viraj, my first question is very specific. And as I told you yesterday also that we have 25 minutes. So let us discuss the points which are relevant. In your practice, in a metastatic or unresectable gallbladder cancers or biliary tract cancer, what is a 5-year overall survival, 3-year overall survival, 2-year overall survival, and 1-year overall survival?
Yeah, great question. So if I remember, for 5-year survival for biliary tract cancers as a whole group, it's just anecdotal reports. I wouldn't be able to.
Viraj, can you increase your volume, please? Viraj, can you increase your volume?
Now, is it better?
Yeah, it is better.
Yes, so 5-year survival, as I was saying, would be just one or two few anecdotal case reports that everybody has. But generally speaking, it is close to zero, if not zero. I don't know about 3-year, but 2-year survival is about 1 in 10. That's what we tell patients, that you have about 1 in 10 chance to make it to 2 years. And about 30 to 40% generally cross 1 year. The median survival for biliary tract cancers as a whole is less than a year. We know from several trials. So that is the same experience we have in our center as well.
Absolutely right. And that is what we see. In fact, north of India, and Ullas in his panel may highlight, north of India sees a lot of gallbladder cancers, and we see a lot of metastatic gallbladder cancer. I remember 3 patients who have crossed 3 years. That's all. You know, if I remember. Otherwise, majority of them succumb below that. So Viraj, one very, very important question. We discussed that yesterday also, but today I want you to say that again, because there is a lot of discussion in WhatsApp group of ours where people have talked about median overall survival. Okay, so when there is a dismal 1 year that hardly 10% are going to cross 2 years, according to you, should we be looking at median overall survival, or should we be looking at people who cross 2 years, 3 years, 4 years? How would you look at these papers?
So very great question. Until recently, before the era of immuno-oncology, all we had was chemotherapy. So the medians made sense because invariably patients who do well on chemotherapy will eventually drop off. So that would reflect the median survival. But with immunotherapy into the picture, we know that patients who do well can go on the tail of the curve. So it's the landmark analysis which should be the main focus and not the medians. And it's not only in biliary tract cancer, right? If you see lung cancer or any other cancers where you have immunotherapy, the medians are at best 2 to 3 months benefit.
Correct.
But if you see the landmark analysis or the tail of the curve, that's where the whole fruit of immunotherapy is. So I completely agree with you. Unfortunately, the current clinical trials cannot be designed based on those as an endpoint, like 3-year OS. You can't design a good statistical sample size to do a trial, and hence median is a de facto primary endpoint. So
I agree. You know, IO alone trial, if you remember IO alone trial, when they started coming, I used to laugh at myself. I said PFS of 2.3 months and 2.5 months, and what are they talking? And then when you see the tail, suddenly you realize that every cancer we have IO approvals. So that brings us the another most important aspect of IO trials, Viraj, conditional survival. Do you believe in conditional survival, and can you elaborate what is conditional survival?
Absolutely. So it's on the same concept as we mentioned before. What I do tell my patients is, if you can make up to 3 to 4 months with a response on immunotherapy, these are the kind of patients who we push the button and force them to go on for long, because these are the usually patients who would go on to be on the tail. Invariably, about 30 to 35%, 1 in 3 patients would drop off immediately within 2 months. And it can be any cancers. So there is always 1/3 of these patients who will not do any good on immunotherapy. So that's what I tell. And it's completely the opposite of chemotherapy. All chemotherapy, when they respond, they eventually drop off. While immunotherapy, if they respond, they go on. So it's so contradicting two different set of therapies that we have. So we need to change our counseling methods. That is, we tell them that if you cross this line, then you are on the tail. That's what I do.
Absolutely right. Viraj, another important question, which at least I'm dying to hear from expert like you. Intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancers, are they biologically different?
Yes.
Do they respond differently to different treatment?
Great. So you asked two questions. So I'll answer them differently. So until recently, in fact, even in the last trial, all these three subsets of biliary tract cancers are always clubbed together in any metastatic disease or adjuvant setting. It is very intriguing that, all of these three subsets have a biliary columnar cells lining within them. But if you see the distal bile duct or the extrahepatic ducts or the hilar cholangiocarcinoma, they behave more like pancreatic cancer. And molecularly also they have KRAS mutation. While if you see the intrahepatic cholangiocarcinoma, they develop embryologically along with the hepatocytes. And you see completely different mutation profiling like FGFRs and IDH and BRAFs. And gallbladder, the third subset, which completely does not behave like biliary tract, it is more of HER2 overexpression. We have two papers, at least from India, Tata and from the north, which suggests 15%, as high as 15% of gallbladder cancers overexpress HER2. We know that they do well on trastuzumab. This year, as GI ASCO, we had a paper on TDXD on that. They do very well, 40% response rate in second line setting. So it is amazing. So all three, unfortunately, because of lack of incidence, are always clubbed together. But I think so in coming next year, 2020 plus, they would be subdivided based on their biology or molecular profiling.
Absolutely right. And the second part, would you treat them differently or would you give them Gemsys, all of them, right now, 2022, October?
In metastatic setting, it is Gemsys ABC02 trial, which remains still the de facto go-to regimen for advanced disease. Having said that, we all have started using nab-paclitaxel as a triplet based on the MD Anderson data, especially when you are treating neoadjuvant way or borderline resectable way, where you're shooting for a response. But otherwise, currently, Gemsys remains standard for all three of them. While in adjuvant setting, it's very strange that Gemsys does not show improvement in survival. It's the capecitabine 5-FU based treatment.
Right.
We don't know the answer for that, but we know the gallbladder cancers are not the cancers who do well on 5-FU based treatment. Even in BILCAP, the subgroup analysis shows that the adjuvant capecitabine did not do much benefit to this cohort. So it's the so 5-FU is a slightly skeptical drug for me. Having said that, one or the other lines, they will end up getting 5-FU in my practice, but it's not a great drug for gallbladder cancer.
So, Gemsys followed by Folfox, Folfirinox, capecitabine, then S1, all these are the ones which we play around. And today we are talking of Durvalumab. So we have 13 to 14 minutes more, Viraj. Let's jump to the paper.
Sure.
So in the paper, I have few queries. The Topaz 1 trial, which I presented the slides. The first is, according to me, we have scarcity of response in biliary tract cancer. And if we look at the phase 2 data before the phase 3 trial came, it was a very, very, encouraging results. While phase 3 it changed. What is your take on this?
Yeah. So you did mention in your presentation about a phase 2, it was about 100 patient data, all from Korea. And the response rate was 70%. It is strikingly different from what we are seeing in phase 3 right now. And disease control rate of almost 100%, 97 to 100%, with overall response median OS of 20 months. But we all know that phase 2s tend to be different and phase 3 shows a different picture. And hence we have to be cautious in using nab-paclitaxel as our third drug because of 19 months OS in that phase 2. We have to wait for the phase 3 to come up and show us that that is better than Gemsys. There is also a Folfirinox study comparing with Gemsys in advanced biliary tract cancer. It did not show any benefit. And I think even Dr. Atul Sharma and his group did a trial of neoadjuvant Folfirinox. That also did not show any better control compared to Gemsys. So currently Gemsys still remains the best regimen.
Absolutely right. So coming to phase 3 Topaz, today's paper, Topaz 1, I'm little intrigued about the dose of Durvalumab, Viraj. 1,500 milligram every 3 weekly. And if you look at the lung data, 10 milligram per kilogram is the approved dose. So for 1,500, that means we are assuming 150 kg guy. I feel the little more dose was selected. What is your take on that?
So first of all, it's not little more dose. It's a hell of a dose. We all know this is the same story with Nivolumab. This is the same story with Pembrolizumab. They all started with 2 mg with Pembro, 3 mg with Nivo. And when they want to prolong the duration, dose intensity, they make it flat dosing. And there is a fantastic paper in JAMA by Dr. Goldstein, which showed that why using flat dosing has no clinical relevance. It has only commercial aspect to it. So let's keep that aside. But if I have to endorse Durvalumab in GemCis, it has to be 10 mg per kg. That's a reasonable dose for it.
Can I just interrupt? Viraj,
yes,
is it possible to increase your volume? Some people are still not able to hear you. Back to you.
Sir, he's audible actually, sir. I think Amol.
Some people,
yeah. I'll try and shout.
Okay.
So,
गुज्जू भाई को चिल्लाने की जरूरत नहीं पड़ती है, वो ऐसे भी चिल्लाते ही रहते हैं.
Strikingly, 1500 Durvalumab did not have any adverse events, which one would have thought. So yeah.
So the receptors must be getting saturated. उसके बाद में विटामिन सी जैसे होता है ना, 1 gram के ऊपर सब यूरिन के थ्रू निकल जाता है. Probably we don't know about that.
You made a nice analogy about rituximab yesterday. So I think
correct.
All the MABs, we have to see the lowest possible dose which can saturate the receptor.
Absolutely right.
And not
Absolutely
the MTD, because there is no MTD for these MABs.
For rituximab, there was no MTD at all. 2,500 milligram per meter square. There was no dose limiting toxicity, but we still give 375 milligram per meter square. Viraj, second question, I will not talk about cisplatin for the want of time. We all know that 25 milligram per meter square was ABC02 dose, and that is what has been used in this trial. Very quickly, in 20 months flat, out of 105 sites, 914 patients were enrolled. I think this is one of the fastest recruitment. Is biliary tract the need of the hour, or was it the faster than usual enrollment, Viraj?
So both. We have a high unmet need for BTCs because we only have GemCis. And this trial just shows the power of global recruitment. If you have 100 sites, it's just 8 to 9 patients per site in 2 years. So 4 patients, you would enroll them. So, and if you have 100 sites, so you can enroll these fast. But yes, I agree, it's an area where we have unmet need as well. And somebody writing need for the hour for 8 years.
Dr. Govind Babu, I can see that. Viraj will move on. There was a talk about 18 months overall survival and 24 months overall survival, and there is an anticipated overall survival. And we all know that this paper was an interim analysis paper, and it met the utility and futility analysis, and that's the reason it was unblinded. Topaz 1 is still ongoing, we all know that, but the papers say that you take this as the final results. Some people argue in this group also and in WhatsApp group also that the 24 months was the estimated that 25% versus 10%. My take is that, 1/4 of the patient crossing 2 years versus 1/10 of the patient crossing 2 years. Am I reading right, Viraj, or am I being too optimistic here?
So this is how I am reading, that 1 in 4 patients, and this is what I have started doing since last 6 months. And while putting Durvalumab to these patients, that you have 1 in 4 chance to make it to 2 years and perhaps even longer, because we know if patients do well on immuno, they usually don't drop off. But like you said, these are estimates. We still need longer follow-up. This ESMO, they presented an 18-month survival, and that just gives us confidence that that gap, which they estimated in earlier last year, has still maintained in actual real life as well. So
it was still 35 versus 25%, right?
Correct, 35 and 25.
Great. So I think I also agree with you that 18 months exactly showing what they anticipated. I don't think that they would be wrong when the actual number at risk increases in the Kaplan-Meier group. that is there. Govind Babu sir, there were an Indian site. Tata Hospital was one of them. Viraj, quickly moving on. We have 5 more minutes. Hazard ratio in IO studies. I know you have a keen interest in statistics, so I can afford to ask you this question. Hazard ratio in IO studies, again, I say, when, in 6 months, the lines are flatly touching each other and then they start separating. And here also, if you see, the hazard ratio for first 6 months was 0.91 and after 6 months was 0.74 and total it was 0.8. Should we be using hazard ratio at all in IO studies?
Absolutely. So this goes back to the same question, that if your primary endpoint is median, then your hazard represents the median. But if your primary endpoint has a landmark analysis, then your hazard represents that landmark. So at 6 months landmark analysis, it is nothing. But at 24, 18, and 24 months, you start seeing the hazard ratio far better what we would expect. So for the median OS, hazard is 0.8. And it's the same problem, right? That if you are taking median as your endpoint, that hazard represents that median. But I agree with you, it should be the landmark analysis which should have a hazard.
Right. Very, very controversial area about TAP, PD-L1, the way calculated, tumor area positivity.
Yeah.
But at the same time, when I look at the formula for CPS, is not much different. Do you think that TAP was okay to be used, or they should have used something else?
No, so you are right. TAP scoring is just a new nomenclature for the CPS that we do. The only thing which was perplexing to me was why they'd used SP263, because in GI cancers across the board, we use DARCO platform. But probably they were taking their lung cancer data into the same biliary tract. So it's a Ventana platform. But what I do in my practice is just stick to DARCO platform 22C3.
Perfect. And there was not much of a change between MSI positive or negative unless until you take plot. So that is my second last question, Viraj. Forest plot chart. If you see the overall survival, PD-L1 more than 1% based on TAP, intrahepatic cholangiocarcinoma, Asian population, and locally advanced disease did not cross the line of unity. One of the most important thing in PFS and OS, non-Asian apparently look like are not benefiting by Durvalumab, and the Twitter was full of that. And thanks to Dr. Manu from AstraZeneca, he provided me with a lot of Twitter feeds. There are a lot of discussion about, does Durvalumab ever work for non-Asians? Again, my point is we read too much on forest plot. What is your take on forest plot for Topaz 1?
So I think so Topaz 1 forest plot is exactly what I expected. I don't think so there is any subset which is benefiting less or more. The very good slide that you showed in the forest plot is the gray bar, the gray bar, which people usually tend to miss. It's the confidence interval of your main result. And the way to look at forest plot is, if any of your lines, the confidence interval of any subgroup touches that gray bar, it is significant, right? So whether the line is this side or touching the unity, that's not how the way you read forest plot. And I always tell my residents here, there is an excellent paper in JCO editorial called Thursday Child Has Long to Go. It's a fantastic statistical analysis of Stampede trial. I urge everybody to go and read that, where it showed that if you are born on Thursday, Friday, Saturday, you are going to do twice as better as if you're going to born on Monday, in the same data set where it was showing that Abiraterone is better. So it's just reading too much. So I agree with you. We should not read too much in forest plot. I think so every subset did equally well.
So I know you have started using, and I have started using Topaz 1 in my practice, Viraj, but my last question to you is, and there is a rider on that, with a median overall survival difference of 1.6 months, Durvalumab 1,500 milligram at such a large cost, can India afford to do that? Is the question. Under that rider, why would you decide to use Topaz 1 today in your clinical practice, Viraj?
Yeah, so that rider makes it difficult to answer.
And Amol said it is only 39 days, not even 1.5.
So under that rider, if you are going to consider median as your selling point for immunotherapy, and that too with 1,500 dose, the answer is very easy, no. But what I do, and what I know what majority of people do, is use 10 mg per kg dose. And we tend to tell the patients about the landmark analysis. We are, attracted to the tail of the curve and not the medians. So in that sense, I have started using this regimen in my practice. Also like to add one more point, that we are soon going to have Keynote 966 results by ASCO GI in 23. And it's the same study's design, except one difference, where instead of placebo, they have also allowed gemcitabine maintenance. So if that study is positive, the debate is over, period. Immunotherapy has to be used along with chemotherapy first line. But God forbid, if that study is negative, then people are going to crush Topaz that, it is the maintenance versus no maintenance that won them, and not Durva versus no Durva. So yeah, we'll have to wait few more months. So will I endorse the whole country to start using this in India? Probably we'll hold on for a few more months and wait for Keynote 966.
Okay. And Amol, your question on gem maintenance, I'm sure Ullas will cover in his panel discussion. We are 1 minute out of our time. And Viraj, thank you so much. I always, whenever I talk to you, I learn at least few things from you. And today also I learned, and I'm sure people who are listening also learn from your experience. Continue doing the good work, what you are doing. Over to Parikh sir, but Viraj, you stay because you are one of the panelists also.
Thank you. Thank you.
Thank you very much, Viraj and Amish. I think the discussion on the manuscript has really set the ball rolling. And now we will have a lot of intense discussion on many of the points that some of our faculty have already put on the chat, as well as which have been circulated since morning on WhatsApp group. But I will leave all of that to Dr. Ullas Batra. It is my honor to introduce him. He is senior medical oncologist from Rajiv Gandhi Cancer Institute, and well-known and respected prolific speaker, moderator, who is always there in major conferences, not giving one talk, but more than one talk. So without taking too much time from you, Ullas, over to you for the panel discussion.
Thank you, sir. And Viraj, it was fantastic. I mean, I could see a spark in your eyes and Amish's eyes. Amish wrote down that Thursday thing over there. I'm sure he will go and read. I will go and read that tonight. So I mean, I think this is the love for learning which keeps us going. Actually, and when it is about learning, can I please invite my panelists? And my panelists over here today are Dr. Shyam Agarwal, my favorite panelist, sir. When in doubt, I Dr. Shyam Agarwal, Dr. Nilesh Lokeshwar from Mumbai, Dr. Roshni, Amol, who is very, very active right now, and 39 days and 20 days. I think Amol has already written a set of questions, and he's just pasting them onto the WhatsApp group. Dr. Govind Babu and my teacher, Dr. Nikhil and Akhil. Can you guys, all the panelists, please switch on your video so that it becomes easy to know that who is sleeping and who is not. Okay. So
Last, did you mention Roshni? She is also on.
Yes, I did. Okay. I did. Roshni, yes, and Viraj also, obviously. And Amish, you're also one of my favorite panelists. So please stay on over here. Okay. So critical analysis of Topaz trial. My first reactions when I was asked to do this opto, and when I first thought about Topaz trial, when I first Google searched about Topaz trial, was this. Durvalumab significantly improved survival for patients with biliary tract cancer compared to chemotherapy alone. And this was a January 18, 2022 release. And my first reactions over there was finally, ever since I have finished my DM in 2008, there has been no improvement. So I was waiting, somebody will improve on GemCis, the ABC2 trial. And finally, we got something which was positive, and this was a significant response to treatment. My subsequent reaction on Topaz trials was this is opto. This is oncology beyond the obvious. So, there must be something about it. Then I realized this, so I thought, let's have a perception versus a reality battle. So immunotherapy in biliary tract cancer. Today we are going to discuss about the perception versus the reality. whether this is the perception of Durvalumab which is there, which Amish is looking at, or this is a nice looking cat which is there. So I think my panel of experts will help me in telling me about this perception versus the reality battle in biliary tract cancer. So let's just go ahead with this. And this is a phase 3 randomized double-blind placebo-controlled study of Durvalumab in combination with gemcitabine plus cisplatin in patients with advanced biliary tract cancer, TOPAZ 1. I think Amol asked this question in the morning. So Amol, why will they name it TOPAZ? I mean, the first question goes to you only. Why did they name it as TOPAZ? I mean, where is the T and where is the O and where is the Z in this?
Apart from AZ, am I audible? Sorry.
Yeah, Amol, you are very audible.
Yeah, apart from AZ standing from AstraZeneca, I cannot figure out why it is TOPAZ.
So maybe the AZ comes from AstraZeneca. That's a very nice thing, actually. Anybody, Nikhil?
I think I am equally fluxed with why this TOPAZ name came from. So I did my part of it after discussing again, but I think probably Amol is right. Amol is really for chasing the pharma companies.
Top of AZ, top of AZ was TOPAZ 1. Okay.
So it must be top expectations.
Yeah, top expectations from AZ. Fantastic. Viraj, any?
AZ at top.
I think when they had the phase 2 trial, they have another IO drug which they used in Korea, which starts from T. I'm not able to remember the name. That also was one of the trial arms. So maybe the T comes from that.
इतना मुश्किल नहीं है अमोल. इतना मत सोचो इस बारे में. This is the mail I got from there. Durvalumab trials are named by convention. So for lung, you are called as Pacific, Caspian, Aegean, and Adriatic. For GI, you are looked as gemstones or mountains, such as Emerald, Topaz, Himalaya. So don't read too much into this. I mean, let's just take a chill pill. So at least, Amol, now I can switch off my moderation. There is one question that I asked which you didn't know. I will switch off my moderation right now. I can rest in peace now for today's this thing. This is the first panel discussion in which the moderator and the other panelists are very scared of coming over here. Okay, let's go. So this is a study design which Amish very rightly said, double-blind, multi-center global phase 3. And this was, the eligibility was locally advanced or metastatic biliary tract cancers, which included intrahepatic cholangio, extrahepatic cholangio, and GB. And even the exploratory endpoints were, about ICC versus ECC and all. So my first question to everybody here, and I'll start with Nilesh. Nilesh, I mean, Amish also asked to Viraj. I mean, is it GemCis all the way? And Viraj very rightly said, they don't give capecitabine over there. To me, I mean, anybody with the biliary tract cancer is a GemCis, or do you treat them differently?
So as of today, I do treat them similarly. Having said that, I'd probably categorize them into 4 different groups: intrahepatic cholangio, extrahepatic gallbladder, and periampullary, which we forget is often included as a part of this, but which is a completely different entity. We understand that the molecular aberrations in each of these diseases are very different. And while we are really speaking so much about chemotherapy and IO, at least for intrahepatic cholangiocarcinoma, we know that targeted therapies are just around the corner. So I think that they should be treated differently. And in a year or 2 from today, they will be treated differently. Okay.
But right now in 2022,
except for periampullary, the others are by and large.
In periampullary, you will probably give FOLFOX and a 5FU analogs more than GemCis. Is that what you're saying?
Again, based on histology differences, whether it's a pancreatobiliary type or whether it is a duodenal type, intestinal type, yes. As of today.
Let me go to the gallbladder capital of the country, Akhil. Varanasi, UP, Delhi, we see a lot of gallbladders over there. What is your experience? I mean, this is what NCCN says, biliary tract, gallbladder, extrahepatic cholangio, biliary tract, intrahepatic. I mean, do you treat them all differently?
So, sir, basically the treatment we do not treat them very differently. These are usually treated in the similar way, but we know that the mutational profile is a lot of difference, and we get a lot of mutations in the cholangio, but not in gallbladder. If we see, I want to highlight that we are getting a lot of PIK3CA mutations in gallbladder cancers, but while in other cases, in cholangio, we get some more of IDH and other mutations. So there is definitely a difference in biology at least, but treatment is more or less same.
So when you select your panel, Dr. Roshni, when you select a panel for an NGS, I mean, do you have different panels, or just you will send a panel for everyone? Fine, there's a solid tumor panel NGS and send, or do you have different panels for different, IHC different and ECC different?
See, upfront, we are not doing NGS, but during the course of treatment, for those who can afford, we start doing the molecular profile. So if it's like gallbladder, I would ask for HER2/neu first. And if it's for a cholangiocarcinoma, I would ask for FGFR and IDH if I had to choose. PD-L1 testing is not making a difference in any case as of now.
Okay.
If we have to do a limited panel.
Okay, let me go to Dr. Shyam Agarwal. Dr. Shyam, sir, do you do NGS very regularly? And does your choice of panel different? As Dr. Roshni said, is gallbladder, you will send a HER2/neu by FISH first and probably send something else later. Does it change?
Yeah, Ullas, you see, certain things also are dependent on what you have in-house. So currently, what we have in-house is HER2/neu, MSI, and CPS. So I think we have begun asking for these three markers, which are fairly, readily available, cheap, and you get the outcome, in 5 or 6 days' time. And I think, as rightly pointed out, we are, not performing the NGS panel or a comprehensive gene panel in all patients. But yes, I mean, these patients, as we all know, don't survive that long. So I think a couple of months, 3 months down the line, if we find somebody affording, then we ask for a single panel for all of them. I don't think we have different panel for different type of gallbladder and the cholangio.
Okay, Viraj, can you explain on the RNA sequencing bit which you wrote in the comment for intrahepatic cholangio?
Yeah, so as your slide shows that all the fusions that we see is predominantly for ICC.
Yeah.
In fact, virtually absent for extrahepatic or gallbladder. So, the routine of Indian commercially available tests usually and the cheaper ones, NGS, focus on DNA only. So you're going to miss all those fusions. So if you are going for intrahepatic cholangio, your panel must have RNA sequencing into it also.
So exactly right. I mean, what we do in our panel is we have two. One is a V3 panel, which is a complete comprehensive panel, and one is a solid tumor panel. So for the intrahepatic cholangio, we ask for the fusions, and that is where we ask for the more bigger. Other ones, we ask for smaller one. I mean, that's exactly what we do. So that was, about, so I do think that, to summarize, all the biliary tract cancers are same, but they are different. And I'm sure in 2023, 24, we are going to treat them very, very differently. So let's start with Topaz once again. Dr. Govind Babu, sir, do you think it's an unmet need? I mean, Amish told 1 year, 900 patients came very easily. Is it an unmet need?
Just to give you a philosophical thing, there's an unmet need for all cancers.
Don't give me a philosophical answer, sir. Give me a scientific answer.
I mean, that is scientific as well, but more philosophical. But of course, yes, for gallbladder cancers, especially in your region, where you see a lot of them. Down south, we don't see so much. For you, it is a big problem. So definitely there's an unmet need.
Okay. Nilesh, your second line of treatment in biliary tract cancer, and in the same context, tell me then, have you ever used a single agent immunotherapy in advanced biliary tract cancer? If yes, what is the response? If no, why?
So my second line option in conventionally is usually FOLFOX or CAPOX. And because that's how the data also is from the ABC6, in second line setting, a 5-FU oxaliplatin based therapy is what is the standard of care, and subsequently irinotecan based therapy. There is phase 2 data for both nivolumab as well as for pembrolizumab, but I have no experience in using immunotherapy except in a patient who had MSI high. Unfortunately, couldn't afford, so I haven't used it.
Okay. Nikhil, what is your experience, and have you used immunotherapy as a single agent in this?
So not in the second line for sure. In general, for the second line patients, most of the times these patients are almost quite difficult and challenging patients by that time, many a times we probably end up using only some 5-FU container like capecitabine or maybe S1 like drugs. To answer the single agent immunotherapy, not really, but I have used certain targets. Just to give an example, we had one patient who was BRCA positive, somatic.
No, again, Nikhil, forget. No, I just want to talk about immunotherapy today. We will not talk about
Okay. So that's about it. So mostly kind of doublet with 5-FU or single agent.
Okay, fantastic. So Nikhil, now I'll ask you to do two things. This was the ABC02 trial, and this is what I will ask you to remember a number called as 8.1. So this was the GEMSS, the median OS was 11.7 versus 8.1, and 8 versus 5 months was the PFS. This is what Amol wants me to remember. So the median PFS was 8 months in the GEMSS arm in the ABC02 trial. Just remember this number. This was the immunotherapy mutation load, and we can see basically that, even for the intrahepatic cholangiocarcinomas, the median TMB loads are very, very less. The MSI high was only 1%. So probably that is why a single agent immunotherapy doesn't work. Now, this was a pembrolizumab second line biliary experience. Overall response rate, hardly anything. 2.4 months of survival, 6 months of overall survival. So Amol, can I come to you now? Based on this, and I'm sure you are waiting for this over here, have you ever used immunotherapy in second line biliary tract cancer? See, if you look at let me finish my question first. If you look at all the trials, the drug will come to third line first, then second line, then first line, then neoadjuvant setting. Now here is a setting where in second line, you have hardly anything. Overall response rate of Durval plus Temi, Nivolumab, some 10%, 11%. Suddenly the drug comes into first line and is a query useful. So your comments on this, and then I'll go to Dr. Shyam Agarwal.
I have not personally used immunotherapy in a second line setting. I feel that the biliary tract cancers are not immunohot, or what we otherwise say. They are immunologically cold tumors, and I am not so sure whether the immunotherapy is going to much work there. It has already been shown that if a single agent doesn't work, probably in the combination with chemo also, it is not going to produce significant benefit. So personally, I have not used, and I don't think so it will be useful in the future also.
So significant is a word that is open to interpretations, Amol. We will talk about significant or not later. Let's go to the immunotherapy king of Delhi, Dr. Shyam Agarwal. Sir, second line immunotherapy in gallbladder cancer. How many times have you used, and what has been an experience? And again, the question, if it doesn't work in second line, then what makes it work in the first line?
Right. So I think the only indication to my mind at this time, before this particular trial, is if the patient is MSI high, or if you have TMB, more than 10. CPS per se does not, tell me to go ahead and use a drug like Durva or Pembro, etc., even in the second or third line. However, I've had the opportunity of using patients bringing those CPS reports in a couple of patients, but the results are not, encouraging at all in those couple of patients. So I think, and why does it work when you combine with chemotherapy? That's an interesting question. So why does it work in lung cancer and a variety of other cancers where combination of chemo and immuno are used? As you see here, I'm sure you're going to come to this. The results are better in patients who are PD-L1 positive than as compared to patients who are PD-L1. The TAP score is less than 1%. So, that we all know. But that's an interesting question, that why, you are the lung cancer king. So you can tell, why chemoimmuno works in a non-small cell lung cancer who are PD-L1 0.
So my question is not that, sir. My question is, even in lung cancer, when the drug came, it worked in the second line first. There was a 20% response rate. Then was an incremental advantage. Even in the other cancers, head and neck cancer, the drug worked in second line first. Then it came to first line. There was an advantage. In this cancer, there doesn't seem to be an advantage in gallbladder at all. In the second line, in cholangiocarcinoma BTCs, and then in the first line, there seems to be some perceptible advantage. Nilesh, your take on this?
So,
after Nilesh, can I say something?
Yeah. After Nilesh, yes, Dr. Amish.
Okay.
So, I think the answer to your question or a hint to that lies in a statement by the authors themselves in the trial, where they said that they have basically expect that the chemotherapy has an immunomodulatory effect. And that in effect also says that probably as a single agent, this drug will not work in this group of cancers.
Okay.
So that's
Okay, Amish, and then Viraj.
So very quickly, 2 patients gallbladder, 1 patient PDL1 100% where was in metabolic CR for 2 years with pembrolizumab in my practice.
No.
One minute.
Amish,
Let me ask Ullas. Today we are in biliary tract. We are sitting as if we are giving crizotinib or alectinib to all 100 patients of lung cancer. We don't know that we need to give in ALK positive patients. You see the 2 papers here. PDL1 positive biliary tract cancer from Korea, you have 11% response rate. Okay. My point is the second last paper. My point is that do we really know which patient deserves immunotherapy? That is the bottom line.
No, that is all right, Amish. I am not saying whether to give or not give. My job as a moderator is to bring out different point of views. I am not here to support Durvalumab. I am not here to go against Durvalumab. My point is to bring the discussion.
Very good.
That is what was told to be by the program directors, Dr. Amish Vora. If you want, I can get you some messages also from there. Okay, let me go to Dr. Viraj. So Viraj, why is it? I mean, it beats science for me.
Right. So somebody in the panel rightly said VTCs are cold tumors, and at best response rates are only 5%. These 10% that you see are again based on MSI. So there were a couple of patients who are MSI. But like Dr. Nilesh Lokeshwar said, that there is a synergistic activity along when you do chemo. You try to suppress the Tregs and let immunotherapy flourish, and that makes a more sense to bring immunotherapy into front line rather than reserve it for subsequent lines. And even in lung cancer, PDL1 0, pembrolizumab response rate is again mediocre at best. But when you give it along with chemo, suddenly it becomes CAT1 recommendation.
So I think the hot and cold tumors, small cell lung cancer are the hot tumors. Immunotherapy doesn't work over there. So this hot and cold tumor, I think, is a fragment of our imagination, and we don't. This is what somebody said. Akhil has said. Yes, Akhil was about to say the same thing. The hot and cold tumors is something, a fragment of our imagination, and there is no harm in saying we don't know. We will come to know in another 2 years' time. We don't know as yet. So Akhil, your take on this?
Yes, sir. So the problem is that we are unable to identify which patients are going to benefit. That is the only problem. So hot and cold, all these are hypotheses. We don't know what is the real answer. So these are the ways we try to explain the situation. But yes, there is no perfect biomarker.
So my take on second line immunotherapy, single agent in biliary tract cancer was utna maza nahi aaya. I mean, it was not a very great thing. We would have expected better. So let's.
Ullas, can I add?
Yeah, sure.
Ullas, can I add a comment here? Yeah. So it has also something to do with the kind of tempo what we are looking at as far as diseases like these are concerned. When you try and see this particular cholangio in the second line, the time is very short. So when you try and compare with the lung cancer, where there is still a bit of slowness in those tumors, so it is very difficult to really see that kind of benefit in those patients. That's probably might have happened as an advantage, and which probably might have been reflected in the first line, where you get slightly more time for that drug to act. Possible.
Fair enough. All hypothesis generating thing. So this was the trial that Viraj was talking about. Second line, the rationale behind this trial, where GEMS plus CIS was divided into 3 cohorts. One was a biomarker cohort, number 1. The second was a biomarker, the GEMS is the Durvalumab, and the third one was GEMS is the Durva and Tremi. So based on this, it was 73.4%. Somebody remembered, I think Akhil, you remember the 8 words, 73% was the response rate. So this was, I mean, I don't know whether I'll get time ahead or not, but for all the students who are listening, phase 2 trials, let's give them that much importance only. More importance should be given to a phase 3 trial, because you will see that the response rate had come down to a lot lesser in the phase 3 trial. So the reason behind selecting Durva plus GEMS and not with Tremelimab was the 73% response rate. There was not much difference between the 4 and the 3 drugs. So this was again, which was over 73%. So what about the trial design? Dr. Roshni, happy with the trial design? Amish, went gaga over this. Are you happy with the trial design?
Initially Rashmi and then Dr. Govind Babu.
The trial design is okay. They included the standard of care as the comparator arm. Only thing if they have included regions, there are some regions which I don't think they have adequately represented, like South America for gallbladder cancers. Gallbladder cancers are more common in India, Japan, and South America. So if you underrepresent, the results may be skewed.
I will personally go to Brazil and get the gallbladder thing done over there during the FIFA World Cup. Definitely, I'll go over there at that time. Dr. Govind Babu, sir. Happy with the design,
Ullas,
sir?
you can
Sir.
recruit from India. I don't have to go to Brazil.
No, sir,
Exactly, but then
I'll go to
Okay.
Brazil and recruit from India, sir.
Good one, good one.
Okay.
You want a copy? I am there. Okay.
Okay, sir.
So to the design, they have chosen a poor comparator arm because this comparator arm does not have a maintenance like you have Durvalumab.
Okay.
They should have had that, I feel.
Okay, so I mean, Dr. Govind Babu, as usual, my teacher will bring out something which I wanted to ask. So this is, this was the thing over there. Do you ever stop not talking? So my question now to Dr. Shyam Agarwal is, sir, how many cycles of chemo do we give, sir? 6, 8, 10? And what happens to, do you ever stop in gallbladder cancer? I mean, the senior oncologist, sir.
Right. So I don't believe in maintenance therapies, except maybe a patient with breast cancer with metastatic disease. So I usually, stop at 6 cycles by and large, and then I'd like to perhaps go on some kind of targeted therapy, to say, an EGFR inhibitor empirically. But I don't. I think I'm in agreement with the trial design, because the tolerance for chemotherapy beyond 6 cycles is not there for majority of the patients.
Okay. No, I agree with you on that, Shyam. Tolerance is fine, but when you're comparing a maintenance Durvalumab versus placebo, I'm talking of the trial design. That is a wrong design.
No, but then the standard of care still is chemo alone, for about 6 cycles.
Yeah, then the first arm should not have had Durvalumab maintenance.
Yeah. So the point over there, what Dr. Babu and Dr. Shyam Agarwal were debating is that 8 cycles, I mean, they should have given till progression.
Yes.
So, you cannot stop till 8 cycles over there. This is what Amol will come to. But Amol, just wait, hold your horses right now. Let me go to Nileshwar. I'm on your side only, Amol, don't worry. So Nilesh, what happens? What do you do?
So at a practical level, I don't give beyond 8, and I definitely don't give maintenance in this disease.
Okay, so
I don't think there is any data for it, so I don't give it.
So there
and
is no...
honestly, by the time you reach GEM-CIS for 6 to 8 cycles, most patients are not able to tolerate also.
They would either progress or they will not be able to hear. So you can give them whatever you want and say whatever you want actually at that time.
Yes.
Okay. Nikhil, what do you do?
I agree with Nilesh. I think beyond 6 cycles, of course, this trial has mentioned 8 cycles, but after 6 cycles is a challenge even in Indian patients. I think most of the patients won't be able to tolerate that. So most of the patients will be on observation post 6 cycles.
Okay. So observation. So what
Ullas, I think you jumped the question from trial design to maintenance.
Okay. Okay. Amol, what is your take? What do you do in your clinical practice?
In my clinical practice, if the patient is responding to GEM-CIS and his physical condition is good, I try to continue as much as possible, especially with single agent gemcitabine, if the cisplatin tolerance becomes difficult.
So what Amish is also...
If the drug is working, we should not get it off unless it's a toxicity or progression. And quite a lot of patients tolerate single agent gemcitabine well and do well as far as the disease control is concerned.
Okay, so I think we also you can see in this panel only, we are not sure about 6 cycles, 8 cycles, maintenance, switch maintenance, conjugation maintenance. So probably they had to use something. So that is why probably 8 cycles was used. And Amish is absolutely right. There is no data of gem maintenance. There is no data of stopping also. You can give it till progression. So this was the endpoint that they used, and which was there. This was the second point was about demographic and baseline characteristics. Is this, Akhil, in your practice, gallbladder 25% and intrahepatic cholangio 55 and 20% for extrahepatic? Is this the one which you see in your practice?
Not at all, sir. It's more than the reverse also.
Okay, it is more than
80%
Okay. Nikhil, in your practice, and Dr. Roshni then?
So even down south, we see a lot of gallbladder cancers with us. And of course, we see a lot of intrahepatic. There are very few extrahepatic. So again, the gallbladder seems to be slightly more.
Okay. Nilesh?
In my practice, I would see almost 80% of gallbladder cancers, hardly any extrahepatic, intrahepatic cholangiomas.
So I think
Sorry, go ahead. Yeah.
Yeah. So in our, I think in our practice, gallbladder is much more commoner, which we will come to discuss in the subset analysis also. What I want to ask everybody is, what is this new thing called as TAP? I mean, we knew about PDL1 TPS score, we knew about CPS scoring. And Viraj, I think I'll go directly to you. What is this TAP thing, and does your lab or anybody's lab do? Because when I asked my pathologists about TAP, they said go to the water bottle and drink it over there. Nothing called as TAP in PDL1.
Oh, they didn't ask you to go do tap dancing.
No, sir. They knew my skills, sir. That is why they don't ask me to do dancing on that, sir.
So during their presentation in ASCO, they showed a diagram where the formula for TAP is identical. Yeah, the same one.
I read, man. I read for last 3 days.
So identical to CPS, what we do. The only thing which I'm not happy is using the Ventana clone, because I think in all subsites of GI cancers, barring VTC, we have seen that the response to immunotherapy usually correlates with the DARPO platform and not the Ventana platform.
So I asked Dr. Anita Borges and Dr. Anurag Mehta, there are two differences between the PDL1 TPS score and the TAP score. One is they don't count the cells, there they count the area of the tumor. And in the denominator, they also take the tumor cells plus immune cells. But that makes it more subjective rather than objective. So none of them is very happy with TAP. Why they took it, I don't know, but that is what it was taken. So this is what exactly, as if life was not complicated enough. So
we
now
will incorporate this into AI. We have digital pathology coming up, so we'll do that.
Correct. So let's address the elephant in the room. And the elephant in the room is the primary endpoint. So let me just hold, I mean, Amish is now smiling. Here is where the fun starts, you know. So let me start with everybody's opinion with this. Let me start with Roshni first. So Dr. Roshni, are you one on the belonging to the left side? Fantastic result, or you're not so impressed? So impressed or not so impressed? Let us not make it a Rajasthan and a you know, election time over there. Let's be very honest about it. Impressed, not impressed?
I'm not so impressed, but I would offer the data to the patient and, you know, give them a choice.
Not so impressed, but we'll give. Dr. Shyam Agarwal is smiling on this. Not so impressed, but we will offer the data. Okay, Akhil? Dr. Akhil?
Yes, sir.
See, a single study is not going to help you.
Oh, that's absolutely okay. So not so impressed. Akhil is also not so impressed. Fantastic. Nilesh?
So, well, I do believe that this gives us a message. Unfortunately, we don't have a biomarker to understand who is going to benefit. So, yes, it's impressive that you have something coming up after 10 years. So you just cannot dismiss this off. And this is also going to set the passage forward for several other IOs to be checked in this disease.
So
but yes, not for everybody.
So 2:1. 2 not impressed, 1 reasonably impressed. Okay, Nikhil?
So if you only go by the numbers of OS, probably not impressed. But when you look at those 2 years, I think I am quite impressed with those numbers.
So you have thought twice, Nikhil. Impressed or not impressed?
So as I mentioned clearly, the tails are impressive.
Tails are impressed. So impressed. So 2:2. Good fight back. Good comeback. Dr. Govind Babu, sir.
I'm not impressed. I need to wait for some more data to come in.
So 2:3. Not impressed. Dr. Shyam Agarwal.
I think the data does impress, particularly for the TAP1 positive cases.
Okay, 3:3. Amol is the only one remaining, and we all know the answer for that actually. So we will use our. No, yeah. So I'm throwing in Viraj now. So we have 4:4. So let me, Amol, impressed, not impressed, or super not impressed?
Absolutely not at all impressed.
Absolutely not impressed. Absolutely not impressed. Fantastic.
If you can give that 2 points, then probably that will.
Yeah, I'll come to your points. So Viraj, impressed, super impressed, not so impressed?
Impressed. In fact, I'm using this in my practice.
Okay, so impressed.
10 mg per dose.
So we are at a stalemate, and that is why we will go further and discuss over there. So this is the primary endpoint. So all the people who said not impressed, now what I'm asking you over here is median the gospel truth in immunotherapy and overall survival? Now this is what a basic statistical question will remain. Why you are not impressed is because this data, the two curves are on the top of each other for the first 6 months. After 6 months, you stopped chemotherapy in that, and then it came over there. So is median the gospel truth, Dr. Roshni? Do you think that is the reason you're not impressed?
Maybe because first 6 months the tails are not, the curves are not separating, and after that it separates, and you don't know which patient is going to separate on the curve.
So you don't know what patient, but there are some patients who will do. No, we don't know for everybody in breast cancer. Also, you don't know which patient will respond. Even a T2N1M0 might recur. You still give chemotherapy to them, right? And then also you do an oncotype DX.
But this is like the small cell lung cancer data where we feel we are impressed, and then later on we are not so impressed with the data. And it's just individual patients we are helping out.
So you are basically saying because the median overall survival, as Amol is saying, is 39 months. That is the reason why you still want some more data and stuff like that. Okay.
More follow-up, yeah.
Okay. Nilesh?
So isn't this what we are seeing with most IO data? So if this were two chemotherapy arms that were comparing, then I would be strictly depending on the median OS. But we understand that in patients where we are using IO as one of the arms, we do give a lot of importance to the tail of the curve. And unlike lung, where we have some kind of a biomarker, you don't have a biomarker. That is where the issue is. But I think the median OS is equally important. But here, landmark is something that I'm going to be looking at. So I want to know, at the end of the day, as a patient, I want to know, will I be seeing the 2-year horizon or not? And that's important to me.
Okay, Amish has put his, stuck his neck out and said, I don't think median should not be used at the immunotherapy trials. Amol, I would like, you have been a vocal critic of, this trial on WhatsApp, and I'm very thankful to you for making us think over there. So what is your point, Amol? Why are you not impressed with the two tails which are diverging over there? So what if the curve separated median? What is the problem?
See, problem is that we don't have a good myopathy. The curves are separating after 6 months. If you see the median PFS of the trial arm is around the same point. That means we don't know at the end of at the beginning that at the end of 6 months who is going to get benefited and who is not going to get benefited. The drug is extremely costly, and putting them on a lottery system like this is going to be a very tricky situation. Second thing, am I audible?
Yeah, you are audible.
Am I audible? Yeah. Yes. The second point is that, as I mentioned that in the chat box also, if you see the numbers mentioned at the end of the curve, this entire statement that they are using, that 1 out of 4 patients are alive, is not correct. If you go through their own numbers in the ESMO abstract also, probably the number is 10% versus 5%, rather than the one that they are claiming that 24 versus 10%. So again, I'm not so sure about the validity of this statement that 1 out of the 4 persons are remaining alive at the end of the 2 years based upon the data provided by them only. So considering these two things, that I don't know who's going to do better, I don't have a clear biomarker, and the benefit is very minimal for an extremely costly drug, I'm not so impressed by that.
So 3 points which you have brought out. Benefit is minimal for a very costly drug, and you don't know which patient will benefit. My question to you, Amol, on that would be, we don't know which patient will not benefit, but we don't know which patient will benefit also, no? So there are some people who will benefit. This is just a point. And again, Amol, I am just a moderator. I'm not here to support this. I'm just here to bring out discussion. Viraj, just hold on your horses. I would like to show you certain data which basically come. This article came in 2013, which is evaluation of...
Ullas, just 1 minute. Sorry to interrupt you.
Yes.
So Ullas is absolutely right. Everybody who's listening to it, OBTO platform does not endorse or reject. The whole idea of this platform to have a nice discussion. Go ahead, Ullas.
Yeah. I mean, you didn't need to put that ad across over there in between. No, I only am doing the job for you, no, Amish. Why should you come and do this?
Last,
so this, yes,
another point.
Numbers at the end of the tail. Is that Amol is a valid statement? Can somebody confirm this?
Amol, your voice right now was not clear. Can you please put it in the chat box or get a better connection?
Am I audible now?
No. In the meantime, Dr. Shyam Agarwal sir, can you want to comment?
Can you highlight, Ullas, the issue of responders versus the
I will do that.
24 months survival for responders versus stable disease?
I will do that.
At what time do you get the response? I think that is another important criteria to assess the efficacy.
I will show you. I will show you that, sir. So this is what I just come in 2 slides in that, sir. So basically, this was an article published in Annals of Oncology which said a delayed separation of immunotherapy is there observed in all randomized trial, and this is the median survival came for chemotherapy when you had an early response. The delayed separation of survival is basically there with immunotherapy. These are some 2 graphs which I got. This was their own small cell lung cancer Durvalumab. The curves were by and large on top of each other, and then they separated. This is one, and the small cell lung cancer. This was about ipilimumab plus DTIC versus placebo plus DTIC. Again, in melanoma we have long-term survival data, and melanoma is also an immunologically cold tumor. So here, if you see, till around 6 months, immunotherapy plus chemotherapy, this is 6 months, they were by and large on top of each other, and then they had separated over there. So I also, in this same article, Amol, if you read, they have also quoted Keynote 189. I didn't really find those graphs pertaining to be fit over here, but I do believe that there is some truth in the statement. And for immunotherapy, you cannot only look at the median, basically, which is there. And this is what somebody was asking me about the second line treatment. Whether it changed. So if you look over here, there are 2 things which I wanted to say. I mean, I'm the moderator, but I'm just saying, both the sides of the people, 43%, 49% people took treatment. Immunotherapy was there in 4.7% of people, and we know immunotherapy doesn't really act in second line cancer. That is why I showed you the initial data. So it is not that immunotherapy will act great over there. So maybe, I don't know what is it which was basically affecting. So now let me go back to let me go to Akhil. Akhil, do you think in immunotherapy, median is not really the right thing and we should be looking at something else? And if that is there, Akhil, if we are so intelligent, then why is the trial design people not so intelligent, and why are they still keeping median OS as a survival endpoint?
Definitely, I also completely agree. For IO trials, median is not the right way to look at, because we are actually looking at.
I think Akhil is also connection is not good. Amol, I would like to take your point.
How to select the patients? That is the biggest problem, and we don't have an answer to that.
Okay,
so,
Amol.
Yes.
Amol. Now let us say the median curve separating after that. What is your take on that, Amol?
See, it is good to have a curve separating, but again, what I'm trying to emphasize is that statement of 1 out of 4 survival is correct. If you see the numbers at the end of the curves, not only in this graph, but also in ESMO 2022 abstract, the numbers are not 1 in 4 surviving. So that is something that is probably an inappropriate data which we will be giving to the patients, saying that 1 out of 4 have survived. Then probably the numbers are different. There is an ESMO 2022 abstract where the numbers are clear cut. What is the survival at the end of 24 months in the trial and control arm? And it is not 1 in 4 who are surviving. So that's inappropriate, and we should not be using that. That is what my point is.
So although I do not have that data up front right now with me, I will take your point on that, Amol. Let's forget that number for 1 second. Let's say there is a clear separation of curves over here. It may not be 1 in 4. Let's say it is 1 in 6. Okay. Let's not go on to that. Do you still think that the delayed separation of curves, because the thing which was being conveyed was median was 39 days. To me, median was 39 days in gemcitabine plus erlotinib versus gemcitabine in pancreas, and we never used it. But is immunotherapy the way to interpret immunotherapy the same? That is one basic question which all the students are listening, and I want you to tell them, Amol.
See, it is good to have a delayed separation of curves, provided we know that who is going to get benefited upfront.
Correct. Here, so we don't know
benefit upfront. Suppose the way they have used in TNBC Atizo or other drug, they have shown that those who are PD-L1 more than 10%, there is a clear-cut response. Pembrolizumab, so if something, some biomarker is there which says that if this is present, you are likely to be on the tail of the curve at the end of 1 year or 2 years.
I totally agree with you, Amol. I totally agree with you. We need a biomarker. We need a biomarker.
Timely use the lottery system and too much of money is involved.
Okay. Dr. Viraj, your take on this. I mean, again, let us be very honest about it. There are students listening, at least mine are listening. So is the delayed separation of curves a good thing, bad thing? How do you interpret it as?
So all immunotherapy, and you mentioned an excellent editorial 10 years ago, that it's a class effect. It's not a this trial effect. And like Akhil was mentioning, median, calculating median for these type of drugs is not an ideal way to look at it, because immunotherapy has amazing effect which no other class drug has it, that if you do well, you're going to keep doing well. And hence, I think so that has to be the attractive point. I also agree with Dr. Amol. We need these biomarkers, that who are these? Like we have MSI, right? So we are all happy.
But
Viraj,
2 minutes, just 1 second. Even in gallbladder, and if you are gallbladder or you are intrahepatic cholangio and you are MSIH, the response rate to immunotherapy is only 43%. It is not 80% which is there in stomach and colon.
Yes.
It is only for Amish that I forgot lung cancer and I read gallbladder cancer for 2 days. Okay, so this is what Dr. Shyam Agarwal was talking about. So people who respond, that is one in this, the black one, and who had a CR or PR on Durvalumab plus Gemcis, see, they are doing great. So if you have a CR, PR on Gemcis, and if you are not on Durvalumab, you are going down like this. If you have a CR, PR on Durvalumab plus this, you're going here. So probably again, this shows that, you know, the responses that you will get are going to be more durable, and that is the tail of the tail that we will all talking about. I mean, so I don't know whether you torture the data long enough. I remember Senthil here. I always remember Senthil, and it will confess, but I think there is something to this. Now everything is not good. So Akhil, what was the number I told you? 8 months. Akhil, the number I told you in the ABC02 trial was 8 months. Now, did the control arm underperform over here? Is the question over here, Dr. Shyam Agarwal, sir? So ABC2 trial, it showed 8 months. Now it is 5.7.
Yeah, I understand that, but then there's always this question of cross-trial comparison and so on, you know. So, I mean, it's not possible to sort of make a comment.
Correct. So now I'll go to Dr. Govind Babu, the most frequent traveler in the entire group, sir. So, sir, you really believe that finally, you know, Asians and non-Asians are different? We saw that in Flora, we saw that in Archer. Here again, we are seeing, is it totally different, or is it just a chance more intrahepatic cholangios in here, or what happened over there?
I think it is both, Ullas. You know, you're talking about the newer lung trials. You know, yes. Purvish will remember the ISIL study. It was the same thing, you know. We had almost 90 patients on that study, and that study was negative. But when we saw our own data, it showed that we were different. So in BTC, I think there are two things. One is Asians, non-Asians. Other one is the location of the tumor. So I think both play a part.
Okay, but in the answer that they have written, they have said, you know, with a longer follow-up analysis, they may come up over there, but there is some.
That is a hypothesis that they're
putting. That's a hypothesis. Fair enough.
Yeah. Can I make a comment?
Yes, Nilesh.
So, you know, if you even look at the overall response rates of the control arm, it's 18 and 20%. I mean, even in clinical practice with our patient, I think we get a higher response rate. So it's a question are our gallbladder cancers different from theirs? And that's an important question we have no answer for.
Correct.
So, match fixing?
Match fixing? No, sir. No match fixing right now, sir. Okay. So, Dr. Shyam, sir, we will get a lot of gallbladder cancers. Tomorrow morning, gallbladder cancer, PD-L1 tap 10%. Will you give Durva plus Gemcis? Money not an issue. Your patient, sir.
I think I made that statement that if somebody's tap, it shouldn't dip here, which is wrong. So if the tap is more than 10%, I'm definitely going to offer Durva to the patient.
Okay. Irrespective of the tap, Viraj, your take, gallbladder tap 0 now.
Yes.
And should we be doing tap? Should we be doing tap?
No, so I don't do PD-L1 testing for BTC apart from research purposes, and that too with DACO platform. But I have already started using it on 6 patients now. They're doing well. They're still in the induction phase. I'll let you know.
Okay. So this is what, I think subset analysis are basically subset analysis. Let's not read too much into that. Viraj very rightly said initially. And, especially gallbladder bechara to वैसे कटने के लिए होता है. So when your gallbladder can't take it anymore, just relax on that. PDL1 expression, I think Viraj has very rightly said, we don't want to do anything about that. Let's not do that. Just let PDL1 rest in peace over there.
One comment about, the curve separating out. See, we know how immunotherapy works, how chemotherapy works. I always tell my patient when I start immunotherapy, you have to wait for a long period of time to see the response. Only if you're ready to wait for that, then we will start. So I think the way we are looking at median overall survival is wrong.
Okay.
What you said, the designing of the studies, most of them, I don't know. I mean, I have inherent thing that they're non-clinicians or designing these studies for all these MNCs, so they don't have a clue.
So we have a new job opportunity. Akhil,
Yes.
My last question to you is over here is, in lung cancer, and how can I keep lung cancer out of any discussion? You don't give immunotherapy to people who are biomarker addicted. So Amol, and I totally agree with you, we need a biomarker. If we start doing NGS and we don't give immunotherapy to people who are biomarker addicted, will the response improve? I mean, that's something, which came to my mind. Maybe that is the reason why things are not improving. Anybody can take Akhil first and then Nilesh can take this.
So, sir, situation is different for different biomarkers. So we know that for EGFR and ALK, it is different situation. For MET and KRAS, it is different situation. We know that KRAS and MET patients respond very well to immunotherapy, but the reverse is true for EGFR and ALK. So we cannot say in general for all the biomarkers, but if we know that, for example, if we have more data on IDH1 and 2, and we see that patients are not to IDH1 and 2 driven tumors, then it's a different ball game. But in general, we cannot tell the entire all biomarker positive patients will do differently.
Okay, Viraj, I would request you to, Amol.
Yeah, see, it is not just the presence of a biomarker, but the presence of an appropriate biomarker is important. I give you an example. If you see HER2 in breast cancer versus HER2 in stomach cancer, they're totally different.
Correct.
In a trastuzumab has not yet made into neoadjuvant adjuvant setup in stomach cancer, even though TOGA trial came in 2010.
Correct.
And even though stomach is having HER2 expression. So it is not just the presence of a marker that is going to decide whether the drug can be used. There are other factors also. And hence, it is that we have to have first a marker, and the marker should be useful in that setting.
I totally agree with you.
Ullas,
yes, sir.
If you look at the large data pool of doing NGS or comprehensive genomic profiling,
match NC trials, sir.
In the BTCs. So I think there's data for over 2,500 patients of BTCs, and nearly 50% of these patients were found to be having, mutations in, for example, FGFR or IDH or HER2, etc. So, you do have a point that if these patients are addicted to one oncogene, so they are really going to be the really, really cold tumors, which may not be, responsive to immunotherapeutic intervention. Okay. So I know that subset is very important to my mind.
I'm getting messages from the organizers to shut me up, otherwise they shut me up. So this is the last one that I had, but I think to conclude, to me, I agree with everyone. The results are good, but it could have been better. But I have a philosophical answer from Dr. Govind Babu. Usually the things which could have been better, it could have been worse too. At least it's an opening. It's an opening that we have got. We all want to know which drug for which one. We still are not there. But at least this is a good step, I hope, in the right direction. I hope ASCO GI 2023 proves us right with pembrolizumab arm also. But as I said in the beginning, it was fun. It was fun. It was learning while fine. Thank you to all my panelists. Thank you to Amish and Purvish, Parikh sir for making me read gallbladder finally, and hand it back to the organizer. Thank you.
Thank you very much, Ullas. Thank you very much, all the panelists. as we have been learning to expect, the panel discussion was really intense, and I'm glad that the various points on all sides of the discussion have come out very nicely. Now we have the opportunity to listen to Dr. Amit Rauthan, who really does not need any introduction. There is no top level science discussion that can be complete without his concluding remarks. And today we want to hear what is the place of this TOPAZ study for my practice tomorrow morning. Over to you, Amit.
Thank you, Purvish sir. Thank you, Amish. So as I was kind of listening to that wonderful interview, I actually jotted down notes for the first time to kind of take up things which we could just quickly talk about as an expert conclusion. So as usual, a wonderful panel discussion also by Ullas. So let's. My take on this is I think TOPAZ-1 is the first positive trial we have had in advanced biliary cancer for many, many years. I don't think we can deny this fact. We can debate and we can say we are not impressed with the magnitude of benefit, but it is a positive trial. It is a well done phase 3 positive trial. So we may not be impressed with the magnitude of benefit, but we cannot deny the positivity of the trial. Also, the tail of the curve, absolutely no denying, 25% patients surviving in 2 years. Now, whether you talk of maintenance, no maintenance, I don't think we have seen this era of 25% in 2 years in advanced biliary cancers. So clearly, immuno is doing that. And we know some patients will benefit. Only problem is we don't know how to choose these patients. So biomarkers are going to be a very difficult decision till we don't have further data sets. I think this year we were supposed to hear the biomarkers. We have not heard it. So we'll probably hear it next year of the molecular subsets from the TOPAZ-1. So probably we'll know whether which of the molecular subsets are benefiting or not benefiting with the Durvalumab addition. Another point discussed was dose. That's something we'll all debate about. And dose is always very tricky in the Indian setting because dose is equivalent to cost for us. And this is something all of us will learn to do in clinical practice. And we will need to justify what we do. And as long as our conscience is clear and we are able to justify it to our patients with the benefit, it's absolutely fine. So this is something I think will be very individualistic because it is associated with a huge cost. One discussion about PDL1 which happened, I think TAP is not important. At least that's what we have learned. PDL1 testing in biliary tract cancers has no relevance, at least from the TOPAZ subgroup. So we will not be doing PDL1. If we are offering it, we are going to offer it blindly without any biomarkers. Is it practice changing? Yes, I would say it is practice changing. So if a patient comes to us today and tells us, give me the best treatment you have in biliary tract cancer advanced settings, I don't think we can deny and say, no, immuno does not work. We don't know who will benefit. So we will tell patients that there is a possibility of benefit. And if you are into that segment who gets into the tail, you may get into long-term benefit. So I think we will offer it to our patients. And I think many of us, we have already discussed this. Many of us have started offering it to patients in clinical practice. So there is really no denying it is practice changing. Yes, we are eagerly looking for better ways of choosing our patients. We are looking for better biomarkers. We are looking at a pembrolizumab data set to come out. And all of us are eagerly waiting for these results. So I think I think one more statement I would make is we do talk a lot about drivers in gallbladder cancer. We do so much NGS. We pick up IDH, we pick up FGR fusions. And I know in personal experience, we have collected these patients and kept. But what do you do with them? You don't have the IDH inhibitor. You don't have an FGFR fusion inhibitor. You say you love seeing these 20-30% who have a mutation. So except for HER2, we are able to do nothing. We have some small BRAFs, that small MSI is okay, but rest of them, there is no drugs as of now in India. So I think immuno still plays a role there because we don't have the data set which says whether it works or not. So I would like to conclude, it is definitely practice changing, but yes, we need to wait for further data for subgroup analysis, for better biomarker choices, and also the new IO drug trials which will come in for future. Thank you very much.
Thank you very much, Amit. I think I will pass on to Amish for the conclusion of this webinar. Over to you.
Thank you. Thank you, sir. Ullas, amazing job, and Amit, very good conclusion. one of the important point what I feel going forward is going to be a better selection of patients for any new drug. As Amit said, that you just cannot deny that there is a benefit in magnitude. And in fact, I don't want an answer, but the last question I would want to leave in everybody's mind is, tomorrow, if you have a metastatic gallbladder cancer in front of you, with PD-L1, with DACO platform of 20%, and patient is able to afford everything, would you offer Durvalumab or not is a question. We don't need an answer, but based out of the current discussion, you can decide. Thank you so much. And we sincerely thank everyone for such great support. In fact, first time ऐसा हुआ कि उल्लास का जैसा moderation बढ़ते जा रहा था, the number of participants will keep on increasing. मुझे लगा कि जैसा उल्लास बोलना बंद कर देगा, हो जाएगा. But I think the response is amazing to OBTO, and we sincerely request everybody to keep on guiding us and keep on giving your feedback how we can improve better than what we are doing right now. Thank you so much. And with that, and with Parikh sir's permission, we can close the session for today.
Right, perfect. Just the final thing is to remind everybody that the next OBTO will be on 8th November 2022, which is the second Tuesday of November. Thank you very much.
Thank you.